Okay, welcome everybody. In this chapter, we're going to discuss articulations. This is simply a descriptive term for where bones come together. And what we want to understand about articulations are that they can serve either as sites that support the skeletal system, or they can serve as areas where a degree of movement takes place. So it's basically where two bones meet. These articulations give the skeleton mobility in the case of joints that are slightly or freely movable, and they hold the skeleton together, and that really encompasses all joints. And there's two classifications. There are functional classifications for joints and also structural ones. So if we look at the functional classification of joints, it's generally based on the amount of movement that the joint allows to take place. There can either be no movement, there can be a slight degree of movement, or there can be a high degree of movement. And the way that we classify them are that synarthrotic joints are immovable, amphiarthrotic joints are slightly movable, and diarthrotic joints are freely movable. If we look at structural classification of joints, what we're looking at is the anatomy of the joint. And there's not going to be necessarily a one-to-one correspondence between structural and functional classification, but there are some broad assumptions we can make. So when we look at structural classification, we're examining the material that binds the bones together and whether or not there's a joint cavity. And there are three structural joint classifications: fibrous joints, cartilaginous joints, and synovial joints. Fibrous joints are where two bones meet and they're joined by fibers. This is generally a type of connective tissue that allows the two bones to be sealed together. In a cartilaginous joint, we have cartilage as the connective tissue that seals two bones together. And in a synovial joint, we have a really unique setup in which there's a joint capsule which contains a lubricating fluid called synovial fluid, and then there are supporting structures and hold the joints together, tendons which attach muscle to bone, and ligaments which attach bone to bone. If we look at fibrous joints, they're joined by connective tissue. There's no joint cavity, and most fibrous joints are synarthrotic, meaning that they're basically immovable. And the degree of motion that the fibrous joint allows is based on how long the connective tissue fibers are. Basically, these joints don't allow much range of motion. But one of the things that we have to understand about these synarthrotic joints, these fibrous joints, is that there's a trade-off between the degree of movement and the tendency for injury to take place. Essentially, the greater the range of motion, the greater the probability that the joint can be damaged, and the less motion that's allowed by the joint, the less likely that joint is going to be damaged. So there's three types of fibrous joints. These are sutures, syndesmoses, and gomphoses. So let's look at sutures first. These are interlocking joints that provide essentially a seal for two flat bones to come together. One of the places that we find these types of joints are in the sutures that seal the flat bones of the skull together: the frontal, the parietal, the occipital, the temporal, and the sphenoid bones, just to name a few. They provide protection for the brain. They contain short connective tissue fibers, and they allow for growth during youth because in the newborn, the sutures haven't yet fully formed. There are essentially a lot of cartilage between the flat bones of the skull at birth, and this is to allow the cranial cavity to deform as it comes through the birth canal so that the baby can actually crown and exit the birth canal without significant damage to the brain. And what happens after birth is that this cartilage that's in between the flat bones will eventually fuse and become the sutures that are pictured here. In middle age, the sutures will ossify and eventually fuse, and we call them syntoses at that point. If you've ever held a newborn and you've touched the top of the cranium just very, very lightly, you'll find an indentation on the top of the cranium. That represents a site that's populated by cartilage where the flat bones of the skull have yet to fuse. So that's an example that you can use from real life. Let's talk about syndesmoses next. These are bones that are connected by ligaments. The fiber length will vary. As a result, the amount of movement will vary. There's a little or no movement at the inferior tibiofibular joint, which is shown in the diagram. And there's a large amount of movement at the interosseous membrane that connects the radius and the ulna. Those are the two bones in the forearm. Remember that the radius is on the thumb side of the forearm, while the ulna is on the little finger side. And notice also that when we're examining these ligaments, that they are pale to white in color. And this has a consequence. This indicates that when this type of tissue is damaged, the tendency to heal is going to be impeded because of the lack of blood supply. And this is one of the reasons why very often when you tear a ligament, it's not going to heal on its own. It generally needs to be surgically repaired. Gomphoses are peg and socket joints of the teeth in alveolar sockets, and the fibrous connection is called a periodontal ligament. So you can see here just a diagram of the tooth, and while we're looking at teeth, I think it's incumbent on us to address some of the structures here. This area that's above the gum line is called the crown, and it's covered by an acellular substance called enamel, which is one of the hardest biological substances, and it protects the tooth against decay because in the oral cavity there are bacteria that live off of the food that's not swallowed. They use it for fuel, and as they metabolize this fuel, they turn it into organic acids, and they also produce carbon dioxide, which will acidify any solution in which it's present. And if we don't engage in good dental hygiene, what can happen after a time is that these organic acids can erode the enamel away to the point where we penetrate through this outer layer into this softer material known as dentin, which is shown here in the gray. And from that point on, it's a relatively quick trip for the bacteria to get through the dentin and into the pulp cavity, this area here, or in some cases into the root canal. And the danger that represents is that if bacteria get into the blood, it can cause septicemia. The area that connects the crown to the root is called the neck. This is the neck right here, and this is the root. Notice that the enamel does not protect the neck or the root. There's only cementum around this region of the tooth. As a result, if bacteria make it under the crown, they can easily penetrate the cementum, get into the dentin, and then get access to the root canal or the pulp cavity. This groove right here between the gums, which are called the gingiva, and the tooth is called the gingival sulcus. What sometimes happens if you don't engage in good dental hygiene, if you don't floss and brush regularly, is that bacteria will grow on the enamel, and this will irritate and inflame the gums. This is a condition called gingivitis. Normally, when you floss your teeth, your gums shouldn't bleed, and if they do, you may have gingivitis, or worse yet, you may be entering periodontal disease, which is what happens as the bacteria continue to grow and push the gingiva away from the crown and present now an access route for bacteria to go up and under the crown and get very easily into the neck or into the root, and from there through the dentin to the pulp cavity. And so this is why very often in people that have periodontal disease in advanced stages, it's recommended that we pull the teeth and provide dentures to avoid the potential for bacteria to get into the blood supply and generate sepsis. There's particular risk at that point to the brain. The ligaments that hold the tooth in place, the sockets are called alveoli, and these little ligaments are called periodontal ligaments, and they allow a slight degree of movement in the jaw. Remember that the lower jaw is formed by the mandible, and the upper jaw is formed by the maxilla, and those are the only two bones in the body that contain alveoli for the teeth. The other thing we want to talk about real briefly is the fact that your teeth have different shapes. The broad, flat teeth in the front are called incisors, and they're for chopping. The sharp teeth that are lateral to the incisors, which you think of probably as your fangs, are called your canines, and they're for slashing. And then behind them, at the back of the jaw, are the premolars and the molars, and they're for crushing and grinding, and that is the dentition of an omnivore. Essentially, this is a tool chest that indicates that your diet should consist in equal parts of meat and vegetable matter, fruit, and the reason for that is that you have the dentition to deal with that kind of diet. If you look at the skulls of carnivores, you see something very different. You see primarily incisors and canines and very few molars. And if you look at the skulls of herbivores, what you see are incisors and molars and no canines. And that's essentially the dentition dictating what diet they should consume. Herbivores are supposed to eat vegetable matter, grass and grain and so forth, and carnivores are supposed to eat raw meat and other types of animal protein. And so the dentition dictates what sort of diet they should have. Cartilaginous joints are united by cartilage and they don't have a joint cavity. They're not highly movable, and there's two types. There's synchondroses and symphyses. So let's look at a synchondrosis first. This is essentially a connection within a bone of hyaline cartilage that unites edges of the bone together. An example are the epiphyseal plates, which are found at the proximal and distal ends of long bones, which mark where longitudinal growth takes place up until the end of puberty. And once puberty occurs, the syntoses will replace the epiphyseal plates, and at that point no more longitudinal growth is possible, and at that point the only change in the bone shape is changes in density or changes in width. And another example is the cartilage of the first rib with the manubrium, which is the upper part of the sternum. You can see this cartilaginous joint here, and all of these are synarthrotic, meaning that they provide little to no movement. And in point of fact, if you look at the articulation of the ribs with the sternum as you move down from the first rib all the way down through the rest of the true ribs and then into the false ribs, what you see are connections of cartilage between the medial anterior ends of the rib and the sternum, and it's the slight degree of movement that allows us to expand and contract the chest cavity as we breathe. One of the things that happens as we age is that some of this cartilage will ossify, and eventually what will happen is it'll become difficult to expand and contract the chest cavity, and that will impair our ability to ventilate the lungs. And what that does is it reduces our vital capacity. Basically, it cuts down on our ability to get oxygen into the blood. And so this is one of the reasons why as we age, it's more difficult to maintain high energy levels because it's more difficult to oxygenate the blood due to problems with respiratory mechanics. Now, symphyses are another type of joint. This is where fibrocartilage unites bone. Hyaline cartilage is present as articular cartilage, and this provides strong, flexible amphiarthroses. And you can see an example here with the pubic symphysis, which is where the os coxa meet at anterior midline, and also with the intervertebral discs, which provide articulations between the vertebrae. And one of the things that you notice is that in the vertebral column, you've got quite a few of these intervertebral discs, and their combined slight movement allows the vertebral column itself to actually be quite freely movable. The intervertebral discs are interesting because the outer portion of the intervertebral disc is fibrocartilage, and that ring of fibrocartilage is called the annulus, and then the inner portion is a liquid center called the nucleus pulposus. And one of the things that can sometimes happen if you lift a heavy object in an improper fashion is that you can cause that liquid center to bulge through the annulus, and that's what we call a slip disc. And the danger there, of course, is that can impinge on the spinal cord, which runs posterior to these intervertebral discs through the vertebral canal. And what that can do is produce numbness, tingling, and in some these severe cases, even loss of function at areas where the slip disc actually took place. So again, this is an example of a symphysis which allows some degree of movement. And this is an example of an amphiarthrotic joint. Now, the pubic symphysis, which is where the os coxa articulated anterior midline, is an important joint because it's the flexibility of that joint in the female musculoskeletal system that allows the child to crown when it comes to the birth canal. And there's a hormone that actually causes the fibrocartilage to become more flexible during birth called relaxin. And what this does is produces a higher degree of elasticity in the pubic symphysis around the time that the baby's going to crown. And this allows the cranium to slide through the birth canal more easily. Notice, incidentally, that in the female pelvic region, what you've got is a much wider pelvic inlet and outlet. You can see the pelvic inlet here and the pelvic outlet below. And you've also got a broad angle between where the os coxa articulate at anterior midline, and what that does is provide a wider space for the baby's head to come through. If you look at a male pelvis, what you find is that the pelvic and inlet and outlet are much narrower, and you also find that unlike the female pelvis pictured here, that the male pelvis has an arch between the two pubis bones of less than 90 degrees, whereas the female arch is greater than 90 degrees. And again, that allows, in the female pelvis, the baby's head to come through more easily. So those are some examples of some important cartilaginous joints, symphyses. Now, synovial joints are completely different. These are bones that are separated by a fluid-filled joint cavity, and all of these are diarthrotic joints, and they include all the limb joints and most of the joints of the rest of the body. Examples of synovial joints include the shoulder, the hip, the elbow, the knee, the joints between the fingers, the joints between the ankle and where the tibia and fibula articulate with the talus. Basically, any joint that you think of as freely movable is a synovial joint. And if we look at some of the features of synovial joints, what we find is where the bones come together, they're protected by articular cartilage, which is hyaline cartilage, and it prevents the crushing of bone ends. One of the things that happens as we age is that when we use our synovial joints extensively, slowly what will happen is that hyaline cartilage will wear away. And the reason for that is that you're born with all the cartilage you're ever going to get, and the only thing that happens as you age is that the cartilage begins to erode. And eventually what happens if enough cartilage wears away is that you get bone on bone inside the joint cavity of the diarthrotic joint, and that can produce bone spurs, and those bone spurs can rattle around inside the joint cavity and produce inflammation, and this is a condition known as osteoarthritis. This is the kind of arthritis that everyone's going to get if they live long enough, and it presents primarily in the weight-bearing joints, the hips, the knees, the ankles, and so on. There's another type of arthritis that you may have heard of, which is rheumatoid arthritis, and this is a completely different disease. It is an autoimmune disorder where, for reasons that aren't entirely clear, the immune system decides to turn and attack the tissues of the joint cavity, causing them to inflame and swell, and this produces tremendous pain. The challenge with treating this kind of disorder is that we have to use immune suppressants and anti-inflammatory drugs in order to treat the symptoms of the disease. And the danger with that, of course, is that it suppresses the immune system and leaves the patient open to increased risk of cancer and infection. And that's true with any autoimmune disorder. Other autoimmune disorders include type 1 diabetes, Graves' disease, and lupus erythematosus, just to name a few. And it's another unusual characteristic of autoimmune diseases that where we tend to see one autoimmune disease in a lot of individuals, we tend to see them cluster. So we believe that there is also a genetic component to this. Synovial joints also contain a joint cavity. This is a small fluid-filled space. The synovial fluid is like a biological oil, and it allows freedom of movement. And there's a joint capsule that has an external fibrous layer, which is made up of dense irregular connective tissue, and an inner synovial membrane, which is made up of loose connective tissue and produces a synovial fluid. The cells that do that are called synoviocytes. And you may have seen or heard commercials on the radio or on TV talking about joint supplements. A lot of these joint supplements contain glucosamine and chondroitin, which are important components of synovial fluid. And these advertisements indicate that if you take these supplements, what will happen is that your joint pain will diminish. And that claim is only partially true. One of the things that you have to realize about this synovial fluid is that you generally get all the glucosamine and chondroitin that you need if you eat a balanced diet. And so the only thing that you're doing often when you buy these supplements is you're producing expensive urine or fecal material. So what they're telling you isn't false in the sense that it is an important component of synovial fluid, but the misleading part of the claim is that most diets lack this. And so you want to always listen to these claims with caution. The synovial fluid is a viscous, slippery filtrate of plasma and hyaluronic acid that lubricates and nourishes the articular cartilage and contains phagocytes to remove microbes and debris. This is one of the reasons why a certain degree of physical activity is important to keep the cartilage healthy as long as possible. As long as the chondrocytes are alive, the cartilage won't diminish at nearly as high a rate. And if you're active, what happens is that the synovial fluid, which contains oxygen and nutrients for the cartilage cells, will diffuse through the extracellular matrix and nourish the chondrocytes and keep them alive. And this happens as a result of activity. So a moderate amount of activity is very good for your joints because it keeps the cartilage happy and healthy. If you abuse the joint, obviously you can damage the cartilage through trauma. If you're highly inactive, you're not going to have enough oxygen and nutrients to diffuse into the cartilage to keep the chondrocytes viable, and the result is that you'll begin to lose cartilage due to atrophy. So again, a happy medium is recommended. There's different types of reinforcing ligaments that we see in typical joints. There are capsular ligaments, which are part of the fibrous layer, and there are extracapsular ligaments, which are outside the capsule, and intercapsular ligaments, which are deep to the capsule, covered by the synovial membrane. As an example, okay, there are, if you take the example of the knee, okay, the knee is stabilized by several ligaments. The two extracapsular ligaments are called the lateral, collateral, and medial collateral ligament, and they lie outside the joint capsule of the knee, and they stabilize the knee joint so that it doesn't move in a left to right fashion. Okay, so it doesn't move laterally or medially. Your knee is not supposed to do that. It's only supposed to move in one plane, right? You all know if you bend your knee, what that plane should be. If it's bending in other planes, then it's damaged. The intercapsular ligaments of the knee are a pair that you've probably heard of if you follow sports at all, and those are the ACL and the PCL. That stands for anterior and posterior cruciate ligaments. And what they do is they stabilize the knee in an anterior to posterior fashion. Okay, so we've got lateral and medial stabilizers, and we've got anterior and posterior stabilizers. That allows the knee to basically be restricted in essentially one plane of motion. In addition to that, we have to understand that there are other tendons and ligaments that stabilize the knee as well. Remember that the patella, which is your kneecap, which lies in front of the knee joint, is traversed by the patellar tendon, which attaches to the quadriceps proximally and attaches to the anterior medial part of the tibia inferiorly, and that helps stabilize the knee joint as well. And there are also tendons on the back side of the knee that serve to attach the muscles of the hamstrings across the knee joint to the tibia and the fibula. Okay, so what we have is we have all kinds of support in terms of musculature, tendons, ligaments that only allow the knee to bend in one plane. There's also nerves and blood vessels. The nerve fibers are there to detect pain and monitor joint position and degree of stretching. And then there's capillary beds that supply filtrate for the synovial fluid. Other features include fatty pads for cushioning between the fibrous layer and the synovial membrane of the bone, and articular discs or meniscuses, or menisci, and these are fibrocartilages that separate articular surfaces and improves the fit of bone ends. It also helps to stabilize the joint and reduce wear and tear. In the knee, there's a medial and a lateral meniscus, and they look, if you were to look at the meniscus of the knee, it would look like a figure eight, look like a pair of cup holders side by side. And what happens is that the medial and lateral condyles of the femur fit into the top of those menisci, and that helps them to articulate more exactly with the indentations on the superior part of the tibia, and that allows the knee again to bend in only one axis. Oftentimes when you damage your knee by bending it in a direction that it's not supposed to bend, you can rupture the meniscus, and it has to be surgically repaired or replaced. Bursa are sacs that are filled with synovial membrane. They contain synovial fluid, and they serve to reduce friction where ligaments, muscles, skin, tendons, and bones are likely to rub together. Tendon sheaths surround tendons, and what they allow is for the tendon to slide over structures nearby without producing an adverse amount of irritation, inflammation, and scarring. So, I don't know if you ever had a pair of roller skates, but if you did and you looked at the wheels, one of the things that you saw between the wheels and the axle were ball bearings, and what they allowed was the wheel to freely spin without undue amount of friction, and that's the purpose that's served by these tendon sheaths and these bursa, is an increase in the range of motion without undue irritation and inflammation. So it's essentially a way to lubricate the entire system. So what you're looking at here is just a cross section through a typical joint. This might be, for instance, a joint between the knuckles and the finger. Okay, so this might be between the distal and proximal phalange, just as an example. And what you've got inside here is the synovial fluid. You can see the articular cartilage here and here. This would be the distal end of one bone. This is the proximal end of the articulating bone. And of course, the articulating cartilage is there to pad and protect the bone ends, and the synovial fluid is there to lubricate the entire system. And you can see this inner layer here, which is the synovial membrane, and this is where the synovial fluid is secreted. And it, of course, not only lubricates the joint, but it nourishes the cartilage. And superficial to that, you've got a fibrous layer of connective tissue that reinforces the joint capsule. And then you've got ligaments that traverse the outside of the joint capsule and stabilize the joint. In this case, you only have extracapsular ligaments. If this were a knee, you'd see ligaments inside here. You would see ligaments on either side of the joint, both anteriorly, posteriorly, medially, and laterally, and within the capsule. So this is just, again, another typical diarthrotic joint. Together, the fibrous layer and the synovial membrane make up the articular capsule. Other features we want to be aware of are the periosteum, which is the nutrient membrane that surrounds the outer layer of the bone, and it provides the birthplace for the osteoblasts that eventually become osteocytes. It also contains a large number of capillaries and nerves. The capillaries, of course, are there to nourish the bone, and the nerves are there to provide sensation. And then if we were to look even closer, this is the medullary cavity, and it is lined by the endosteum, and in long bone, this is filled with yellow marrow, which is basically adipose tissue. And what you're looking at here is just the shoulder joint, and you can see a lot of the different features we've been talked about here. Just to orient you, this is the humerus, which is the bone of the upper arm. This is the proximal head of the humerus. This is the scapula, and this little indentation is called the glenoid fossa. The proximal head of the scapula sits in the glenoid fossa, but one of the things that you notice about this indentation is that it's relatively shallow. So in order to have a ball and socket joint that allows the degree of movement that you have with the shoulder, which is one of the most movable joints in the body, we need other structures to support. One of them shown here. The acromion process is found at the lateral end of the scapular spine on the posterior aspect of the scapula, and it forms a bony reinforcement on the superior posterior aspect of the shoulder joint. And then there's another process that's not really visible in this section called the coracoid process that is found essentially on the superior anterior part of the shoulder, and it's also part of the scapula. And it's just those three features, the glenoid fossa, the acromion, and the coracoid process, that make up all of the bony support for that particular joint. The rest of the socket inside which the proximal head of the humerus sits is made up by ligaments and tendons and joint capsule. And so you can see here, if we start, this is the tendon of the long head of the biceps brachii. Notice the tendon sheath that surrounds it. And what this does is allows this tendon to move up and down as we flex the muscle without rubbing on structures that are nearby. This is the fibrous layer of the articular capsule. This is the synovial fluid here. Okay, you can see the synovial membrane secreting the synovial fluid, and the fibrous capsules there basically to reinforce the entire capsule. The synovial fluid lubricates the humerus so that it can move freely within the joint capsule without undue irritation and inflammation. And then you've got ligaments that traverse some of these processes. The ligaments that attach to the acromion process and the coracoid process help to reinforce this capsule so that it's more difficult for the shoulder joint to subluxate, to dislocate. And the labrum is formed primarily by the fibrous portion of the joint capsule, as well as some of these ligaments that traverse these different processes. Okay, so one of the things that we need to understand about the shoulder joint is that if you look at it anteriorly, it doesn't have a lot of bony support. As a result, if we subject it to undue pressure, what will happen is it'll tear. And this is why a lot of athletes that use that joint significantly end up having to undergo rotator cuff surgery in order to continue in their chosen profession. And what you're looking at here in figure B is just an example of how bursa, this is the subacromial bursa, and what it does is it allows the humerus to roll without it rubbing against these ligaments that attach to these processes that come off the scapula. Otherwise, it will produce tremendous pain. Sometimes what can happen is that these bursa can become inflamed, and that's a condition that we call bursitis. So what are some factors that stabilize synovial joints? Well, there's the shapes of the surfaces that articulate, and then there's the number of ligaments and their location, and then there are muscle tendons that cross the joint, and that's the most important stabilizing factor. Muscle tone helps to keep tendons taut. It's extremely important in reinforcing the shoulder and the knee joint as well as the arches of the foot. And one of the things that they'll tell you if you've ever damaged one of these joints is that one of the most important ways to rehabilitate is to strengthen the muscles that cross the joint in order to avoid future damage to the tendons and the ligaments. This helps to stabilize the joint, and this allows also a chance for, say, a ruptured ligament to eventually repair after it's been treated by surgery. Okay, 8.2 in your book will give you a list of joint names, the articulating bones, their structural and functional classifications, and the movements they allow. Star that table, know that material, because it will very likely show up on the exam. Okay, all muscles attach to bone or connective tissue at no fewer than 2 points. The origin is the attachment of the muscle to the immovable portion of the joint, and the insertion is the attachment to the movable portion. The muscle contraction will cause the insertion to move towards the origin, and these movements can occur along transverse, frontal, or sagittal planes. So if you, for instance, look at the bicep, okay, the bicep has its origin on the scapula, and it has its insertion crossing the elbow joint onto the bones of the forearm. Okay, um, there are insertions on the ulna, and there are insertions also on the radius. And what happens when the bicep contract is that that joint will flex, meaning that the angle between um, the bones of the forearm and the bone of the humerus will decrease. When that muscle relaxes, what will happen is it will have extension, where the angle between the forearm and the humerus will increase. Okay, so those are two examples of what we call antagonistic movements. Different synovial joints allow different ranges of motion. In a non-axial joint, we only allow sliding movements. A uniaxial joint will allow movement in a single plane, and a biaxial joint will allow movement in 2 planes, while a multiaxial joint will allow movement in or around all 3 planes. So let's look at each of these in detail. If we look at gliding movements, we're talking primarily about 2 bones sliding over each other's surfaces. Examples of bones that do this are the carpals in the wrist and the tarsals in the ankles. Angular movements include flexion, extension, and hyperextension, abduction and adduction, and circumdiction. And you find these primarily in diarthrotic joints. Rotation can be either towards the medial aspect or towards the lateral aspect. Examples of joints that allow rotation are between the axis and the skull, and the radius and the ulna, where we can either medially or laterally rotate depending on whether the palms are going to face backward in the case of medial rotation or forward in the case of lateral rotation. So in gliding movements, we have surfaces of bones sliding over each other's articulating surfaces. Examples include the intercarpals and intertarsals, and between the articular processes of the vertebrae. And what we're talking about there primarily is where the vertebrae overlap on the posterior aspect between the superior and inferior articular processes. Angular movements increase or decrease the angle between 2 bones, and this allows movement along a sagittal plane. In flexion, we decrease the angle of a particular joint, and in extension, we increase the angle of that joint. In hyperextension, we have movement beyond the anatomical position. Movement along the frontal plane includes abduction and adduction. In abduction, we move away from midline, and in adduction, we move back towards midline. And in circumdiction, we stabilize one end of the limb, and then we transcribe a cone in physical space, and this is a combination of flexion, abduction, extension, and adduction of the limb. In rotation, we have the turning of the bone around its own long axis, towards or away midline. Examples include medial and lateral rotation. Examples are between the C1 and C2 vertebrae, and rotation of the humerus and of the femur, just to name a few. And so here's an example of some of these movements. Gliding movements of the wrist shown here. Okay, so you can see how we can move the wrist either in a medial or lateral direction due to the ability of these bones to slide across each other's surfaces. If we move laterally, that would be adduction. If we move medially, if we move laterally, that would be abduction. If we move medially, that would be adduction. Here we can see flexion, extension, and hyperextension of the neck. Okay, and here we can see flexion, extension, and hyperextension at the hip. Okay, so this is involving primarily the vertebral column and its articulation with the sacrum. Okay, here we're looking at movements that are allowed in the cervical division of the vertebral column. Here we see an example of flexion and extension at the shoulder. Okay, so flexion would be in this direction, extension, and then we can have hyperextension. Here we see flexion of the knee. Here's extension of the knee. Hyperextension of the knee would mean that the knee is injured, because then that would be we'd be moving the knee in this direction. Okay, we draw hyperextension of the knee here in yellow. Okay, this is something we would never want to happen. We would never want the knee to move like that. Okay, here we can see hyperextension of the shoulder, extension and hyperextension, and of course we move this way, it's flexion. Here's an example of abduction, okay, movement away from midline. This is abduction of the arm, adduction of the arm moving back towards midline, and here is circumdiction. We can perform circumdiction with the shoulder, and we can also form it with the hip. Rotation, okay, we can see that between the axis and the skull, okay, also between C1 and C2, and we can also have lateral and medial rotation between the femur and the os coxa. We can also have medial and lateral rotation of the forearm, which also goes by a special name, pronation for medial rotation and supination for lateral rotation. So that's between the radius and the ulna. There's also dorsiflexion and plantar flexion of the foot. In dorsiflexion, what happens is that we lift the toes and keep the heel planted. In plantar flexion, what happens is that we point the toes and lift the heel. And an inversion and eversion of the foot. Inversion of the foot would be where the plantar surface of the foot is turned inward towards midline. You can do this sometimes when you sprain your ankle. And eversion of the foot would be where the plantar surface of the foot moves away from midline. And that's a less frequent type of injury. We have protraction and retraction. We find this primarily with the mandible. Okay, you can stick your lower jaw out, or you can pull it back. Okay, basically, protraction would be sending the mandible in an anterior direction, and retraction would be pulling it in a posterior direction. And then you've got elevation and depression of the mandible. That's basically chewing motion. Okay, so you can do this when you drop and lift your chin when you chew. And then you've got opposition between the thumb and between the rest of the hand. So here we can see examples of these different movements. Here's pronation and supination. Pronation, radius rotates over ulna. Supination, radius and ulna are parallel. Okay, in the supine position, this is what we see in anatomical position. The prone position would result from medial rotation, which is also known as pronation. And here you can see dorsiflexion, lifting of the toes, right, and plantar flexion, pointing of the toes. This is the plantar surface of the foot, and this is the dorsum of the foot, the top of the foot. Here we can see inversion and eversion. Inversion, we turn the sole of the foot inward towards midline. Eversion, we turn it away from midline. And here we have protraction of the mandible, retraction of the mandible. Okay, and here we can see elevation and depression of the mandible. And here we see opposition between the thumb and the fingers. And the reason that this is an important movement is because this is what allows us to write and use tools and generate art and writing. And so the opposable thumb was a major anatomical development in the essentially the production of what we think of as human civilization. There are very few animals that have opposable thumbs, and even fewer that have opposable thumbs and also have the intellectual capacity to use that to generate tools and to build things. And to generate writing and art and so on. So this was a big deal in the course of human evolution. Okay, that brings us to the end of this segment of Chapter 8. Stay tuned for Part B. Okay, welcome to the second half of the chapter dealing with articulations. And we want to address now the types of synovial joints. There are 6 types that are based on the shape of the surfaces that come into contact with each other. These include plane joints, hinge joints, pivot joints, condylar joints, saddle joints, and ball and socket joints. And here we can see an example of some of the different types of joints. This is a plane joint. You would see this between the metacarpals and the carpals. Notice that you have a flat surface articulating with another flat surface, and what you're getting here is a sliding movement, either in the anterior posterior or medial lateral direction. And again, there's cartilage at the ends of these joints, and that helps to reduce the wear and tear on the actual bony ends. Here you can see an example of a hinge joint. What you're looking at here is the articulation between the distal head of the humerus and the proximal head of the ulna, and what you're getting here is monaxial movement in the anterior posterior direction. And you can see how the convex surface of one joint fits into the concave surface of the other joint and allows movement in only one plane. If you think about your elbow, obviously it can only move normally in one plane. If it moves laterally, then obviously there's some sort of injury to the structures that stabilize the joint. So the motions that are permitted here are flexion and extension. Here's an example of a pivot joint. You can see the articulation between the radius and the ulna held in place by an annular ligament. And so what you get here is the ability to rotate around the long axis. This is uniaxial movement, and this is what allows the motions of pronation and supination, which we reviewed in the last segment. A condyloid joint is where the convex surface of one bone fits into the concave surface of another, and this type of condylar joint allows biaxial movement, and this is an example of the articulation between the phalanges and the metacarpals. And you can see here that we have both anterior posterior and medial lateral movement. So if you want to demonstrate that to yourself, make a fist and stick out your index finger, and then move your index finger forward and back, and then move it left and right, and you can demonstrate those movements to yourself. This is an example, of course, of a diarthrotic joint, and there would be a joint capsule and synovial fluid, and also ligaments that would help to stabilize the joint so that it only moves in 2 axes. This is an example of a saddle joint. There's only one in the entire body, and it's between the trapezium, which is one of the carpal bones, and the first metacarpal, which is that part of the palm that's directly under the thumb. And what this allows this particular joint to do is engage in flexion and extension, as well as abduction and adduction. The most important movement here is opposition. So if you take your thumb and you rotate it so the tip of your thumb can touch the tip of your little finger, your ring finger, your middle finger, and your index finger, what you see are examples of those types of movements. Another way to demonstrate that movement, not just with opposition, you can hold your hand out flat, and you can move your thumb left to right. You can move it back and forth, okay? And you can even, to some extent, rotate the thumb, okay? So a lot of possible movements provided by this unique joint in the body. Ball and socket provides multi-axial movement. There's 2 ball and socket joints in the body. Those are the articulation between the humerus and the scapula, which forms the shoulder joint, and the articulation between the femur and the acetabulum of the os coxa, which forms the hip joint. And the movements that are possible here are almost unlimited. You can do flexion and extension, you can adduct and abduct, you can rotate, you can circumdict. All of these are possible because of the anatomy of this particular joint. Because of the great freedom of movement, this joint is one of the most easily injured in the body. Remember that the more movement the joint allows, the more potential there is for injury to occur. Let's talk a little bit about some of these injuries. Cartilage can sometimes tear due to compression or shear stress, undue force on the joint in a plane of motion that the joint isn't used to moving in. And this causes it to fragment and make the joint lock or bind. The cartilage rarely repairs itself, so generally we have to undergo arthroscopic surgery where we actually drill tiny holes into the joint and use special instruments that are guided by fiber optic cameras in order to reattach the ligaments or tendons that might be torn out of place. The ligaments get repaired, the cartilage fragments are generally removed with minimal tissue damage and scarring. And this is a huge leap forward in the treatment of joint injuries. Before the advent of arthroscopic surgery, we used to have to open the joint capsule up completely in order to repair the ligaments and tendons and sew it back together, and the recovery time was much longer. Partial menisci removal can render the joint less stable but still mobile. In the event we're talking here about the knee, and complete removal can lead to osteoarthritis, where we get bone on bone inside the joint capsule, causing bone fragments that leads to irritation of the joint and inflammation. Meniscal transplants can be used in younger patients. Again, the meniscus, because it actually sits between the articular cartilages, can be artificially generated and then reinserted into the joint. The articular cartilage cannot be replaced, because while we can get material that can withstand the shear and the compression stress, we have yet to find a material that will adhere tightly enough to the surface of bone that it won't work its way free. Down the road, perhaps stem cells can allow us to grow meniscus tissue, but for now we have to satisfy ourselves with repair or the use of artificial menisci. And so here you can see an example of a meniscus with a tear in it. This is again the distal head of the femur, the proximal head of the tibia. This is inside the knee joint, and you can see where the rupture takes place, and this is where the surgery would be most effective. Now, sprains are where reinforcing ligaments get stretched or torn. Partial tears are going to slowly repair because of the lack of blood supply to the area. Remember that in addition to oxygen and nutrients, the blood also brings in cells that are designed to repair the damaged tissue. There's three options if there's a complete tear. We can have the ends sewn together, we can replace them with grafts, and in any case, what we have to do is immobilize the joint and wait for it to eventually heal. Remember that if you have a strain, that's generally used to refer to undue force on a ligament. A sprain is undue force on a tendon. Because tendons have some blood supply, they have some potential to heal. Ligaments generally have to be surgically repaired. Dislocations are where bones are forced out of alignments. This is accompanied by sprains, inflammation, and difficulty in moving the joint. It can be caused by falls or by contact sports. We have to reduce them in order to treat them. By reducing, what we mean is we have to set the bones so that they properly articulate in order for proper healing to take place. Subluxation is a partial dislocation of a joint, and the treatment is the same. You have to reduce the dislocation, and then you have to give it time to heal. We also have to do reduction in the case of bone fractures, where we have to get the ends of the bones to meet flush so that they can heal, and as a result perform the same task they did prior to the injury. Other inflammatory conditions that can affect joint health include bursitis, which is an inflammation of the bursa, which are the sacs that are used to lubricate the joint so that we have minimal inflammation, irritation, and scarring. Bursitis can be caused by blows or friction or by infection. We generally treat with rest and ice, and if it's severe, we can use anti-inflammatory drugs. Tendinitis is an inflammation of the tendon sheaths. It's usually caused by overuse of that particular tendon, and we use the same treatment as we do for bursitis. And the acronym is PRICE, which stands for pressure, rest, ice, compression, and elevation. And the idea there is that you reduce swelling, you keep blood flow going through the area, and that will accelerate healing. There's about 100 different types of inflammatory or degenerative diseases that we refer to under the umbrella of arthritis. And it's the most widespread crippling disease in the United States. The people that suffer from this experience pain and stiffness and swelling of the joint, loss of range of motion. Acute forms can be caused by infection, where we call it septic arthritis, and we can treat these with antibiotics. Chronic forms include osteoarthritis, which is a wearing away of the articular cartilage, causing bone on bone, generating those bone fragments we talked about that rattle around inside the joint and generate the inflammation. Rheumatoid arthritis, which is an autoimmune disorder where the immune system attacks joint tissue, causing it to swell and inflame. And gouty arthritis, which is the accumulation of uric acid crystals either inside or around the joint, which produce the same type of pain that you might experience with osteoarthritis. So we could treat these with hydration, with heat, and with drugs that can dissolve these uric acid crystals. Recommendations for people that suffer from gout are to avoid alcohol and to avoid foods that are rich in purines, such as organ meats and red meat. Osteoarthritis is the type of arthritis we get from wear and tear. This is essentially a reflection of excessive use of that particular joint. This causes enzymes to be released that break down the articular cartilage in addition to the physical force that breaks the cartilage down. By 85, half of the Americans are going to develop this condition, more so in women than in men. And that is primarily due to the difference in obesity rates between women and men, and also the difference in activity levels. Remember that a certain amount of activity is healthy for the cartilage. Too much activity is damaging, and too little activity is damaging. Aging alone will result in cartilage eventually wearing away because the chondrocytes will die, and as a result the extracellular matrix will become less stable and eventually peel off the bone. More cartilage is destroyed than replaced in badly aligned or overworked joints, and this causes the bone ends to thicken and enlarge, and it makes those bone spurs we talked about, which restricts range of motion. The treatment is moderate activity, pain relievers, and capsaicin creams, and what they do is they bring blood supply to the area, and that can remove breakdown products as a result of inflammation that can be irritating and can speed healing. And remember, when blood gets to an injury, it's going to help not only deal with potential infection, but also promote now the rebuilding of new tissue. Glucosamine and chondroitin sulfate that we get in nutritional supplements, remember, are not effective because you generally get enough of that in a normal diet. And so these supplements, while the claim that glucosamine and chondroitin are important components in synovial fluid is true, the claim that you don't get enough as a result of a normal diet is not accurate. Remember that rheumatoid arthritis is an autoimmune disorder. Essentially what happens is the immune system attacks the joint tissue, causing it to irritate and inflame and swell. This usually occurs in individuals between 40 and 50 years of age, but can occur at any age. It affects 3 times as many women as men, and the reasons for that aren't entirely clear, but we think it has something to do with hormone fluctuations in women that are absent in men, and these hormone fluctuations can adversely affect the functioning of the immune system. Signs and symptoms include joint pain and swelling, which is usually bilateral, anemia, osteoporosis, muscle weakness, and cardiovascular problems. It usually begins with synoviitis of the affected joint. Inflammatory blood cells migrate into it and release inflammatory chemicals that can destroy tissue. Synovial fluid accumulates in the joint, swells and inflames. A synovial membrane thickens, and this produces pannus, which are basically deposits that cling to the articular cartilage and erodes it. And this causes scar tissue to form and connects articulating bones. And what this does is produce a condition called ankylosis, which further reduces range of motion. So how do we treat? Well, we have to deal with the immune system. We can use steroidal and nonsteroidal anti-inflammatory drugs, NSAIDs, to decrease pain and inflammation, and immune suppressants to tamp down the effect of the immune system on the joint tissue. And some agents target tumor necrosis factor to block the inflammatory chemicals. It can replace the joint eventually if the condition gets too severe with a prosthetic device, which is an artificial joint made often out of derivatives of tungsten or ceramic or plastics in order for the person to at least regain some use of the affected area. And here you can see an example of an individual suffering from rheumatoid arthritis. Generally presents bilaterally and in multiple joints, and it often doesn't discriminate between weight-bearing and non-weight-bearing joints. Very, very painful condition. Gouty arthritis is the result of uric acid crystals depositing in the joints and the soft tissues, which is followed by inflammation. It's more common in men, and it typically affects the joint at the base of the big toe and areas that are distal regions of the body. And the reason for that is that the temperature in those regions is usually a little bit lower than 37 degrees C, and the lower a temperature of a liquid is, the more likely a substance will crystallize out. Basically, it's one of those solubility rules. As you cool a solution down, it's going to be less able to dissolve the solute. If it's untreated, the bone ends will fuse and the joint will immobilize, and we treat this with crystal dissolving drugs. We advocate hydration, and we advocate avoiding diuretics such as caffeine and alcohol, because again, as you remove water from the body, you're more likely to cause dissolved solutes to crystallize out. Lyme disease is caused by a bacteria that's transmitted by tick bites. It's a spirochete bacteria. If you look at it under a microscope, it looks like a corkscrew. And the tick is the vector in this case. And then when it takes a blood meal, it injects the spirochete into the bloodstream. And what it does is the spirochete, as it moves through and between tissue, tags tissues with antigens that are recognized by the immune system as being foreign, and the result is that the immune system finds it difficult to discriminate between the pathogen and between the tissue that's been tagged with these antigens, and the result is that healthy tissue begins to die. We see skin rashes, flu-like symptoms, problems with the central nervous system, joint pain and arthritis. We treat with antibiotics to get rid of the spirochete bacteria, but we also have to deal with the immune response as well. So sometimes we have to resort to NSAIDs and immune suppressants to deal with the long-term symptoms. Okay, that brings us to the end of Chapter 8. Make sure to review this material as it will be covered on the exam, and I'll see everybody in class. Thank you.